at Chestnut Ridge and IRMC at Northern Cambria. At the main campus, Memo Mondays are each Monday from 7 a.m. to 3 p.m. No appointment necessary, just walk in.
Boy, does that seem apropos for this next segment. It is the voice of Indiana County, WCCS 101.1 FM, AM 1160, and WCCSradio.com. Our conversation with Dr. Dan Clark, brought to you by Marcus & Mack, voted Best Personal Injury Law Firm in the Best of Indiana County contest. Marcus & Mack, a law firm representing injured people. Well, we just heard the commercial featuring Dr. Margaret Clark, who is a breast radiologist, and we talk about what she does at the Comprehensive Breast Center at IRMC. Dr. Dan Clark, well, you run the whole shebang over there, the Comprehensive Breast Center, and that's a big concern of yours too, isn't it? The early testing.
Absolutely. Mammograms do save lives. That's been proven. And, a few years back, the, U.S. Preventive Task Force came out with very questionable recommendations, saying don't get mammograms till age 50 and then every other year and then stop after age 75. And that was very loudly put down by the breast cancer societies, the American Cancer Society, the American College of Surgeons, American College of Radiology, all the cancer societies that deal with breast cancer. That the data was completely out of date. They completely ignored studies that showed a dramatic decrease in breast cancer deaths in women who got mammograms between age 40 and 50. Also, breast cancer doesn't stop at age 75. The risks continue through your life. And I heard, my wife, Dr. Margaret Clark, mentioned that, if it's small and we catch it, it's very easily treatable. We don't have to do a major surgery. If you're 80 and you have a small breast cancer on mammogram, we can go in under local anesthesia and do a lumpectomy and get the cancer out of there, and then you don't have to worry about it. We're not going to do chemo, and things like that on elderly patients, but it's very simple to take a small cancer out. Whereas, unfortunately, we still see women who are told not to get their mammograms after a certain age, and then they come in with very large tumors, and then we're asked to do more aggressive surgery, which is a much higher risk, than just doing a simple little outpatient lumpectomy under local anesthetic.
I'm sure we could do an entirely separate program on the insurance ramifications when a questionable recommendation comes from some high-powered medical society, and I'm sure insurance companies pay attention to that, and that probably starts a few fights within the medical community. But for now, let's just settle upon the fact that age 40 is really a bellwether time, and maybe earlier for some who are at higher risk.
Right. And that's for the average risk individual with no significant family history. The average woman should start mammograms at age 40. But if you have a family history or other risk factors, those recommendations change. If you have a family history of breast cancer, the recommendation is getting a mammogram at 10 years younger than the youngest person in the family with breast cancer, except not in your 20s. Because unfortunately, mammograms in women in their 20s are not very reliable at all because the breasts are so incredibly dense when you're in your 20s that mammograms can't see through the tissue. So actually, for a woman in their 20s, breast MRIs are recommended. And that's where referral to a breast expert comes in to make those determinations, what is the best study for them.
Yeah, it's interesting as well that breast cancer once was so very, very common, and probably is just as common now, but more detectable, that there are probably very few women who that age 40 mark really applies to. There probably is a significant enough history in many more women that they should start earlier.
There is a lot of women out there with the risk factors. And, we have a high-risk screening clinic. Dr. Nazine Villamora was on earlier this month. She and I both run a high-risk breast screening program. And so if you think that you maybe have additional risk factors, you can come in and talk to us, and we can figure that out. I heard my wife mention the Tyrer-Cuzick breast cancer risk estimate. That's a calculation we can do of a woman's lifetime risk of breast cancer. And it gives us a risk of your breast cancer in the next 5 to 10 years and also up to age 80. So we can actually calculate if you fall into a high-risk category. Currently, the high-risk category is considered if you have a greater than 20% lifetime risk of breast cancer. And if you do, we have additional recommendations for screening. And the age that screening starts depends on your family history and everything else. And that's, we've talked about genetics before. Genetics changes the whole ball game. But even if genetics are negative and you have a strong family history, we have additional recommendations for more aggressive screening than just yearly mammograms.
Mm-hmm. Screening mammograms are different from the next step. If a screening mammogram turns up something, then there's another mammogram that you go in for, correct?
Correct. And that's called a diagnostic mammogram. So you get a screening mammogram, there's maybe a subtle finding on there. It's not quite that strong that they want to go right to recommending a biopsy. We categorize mammograms, category 0 through 5. And that would be a category 0, and that just means that more testing is needed. And usually the radiologist states on there what testing is recommended. And typically that is a diagnostic mammogram, and they come in and they have a little bit of more intense evaluation of that spot on mammogram, and often is associated with getting an ultrasound at the same time to see if it's really there. Sometimes these subtle findings on mammograms, when the breast is compressed over that area, they straighten out and it's just overlapping breast tissue, and it's like, okay, that's nothing to worry about. Maybe we'll get a 6-month follow-up. Mm-hmm. Other times, more intense evaluation that reveals, okay, we need to do a biopsy here.
It's interesting to me talking with Dr. Bill Amoria earlier in the month about the treatment protocol once breast cancer is detected and the very, very many factors that go into it. Mm-hmm. And it got me to wondering, are the treatment protocols different from facility to facility? Does IRMC have a more stringent protocol list that they follow than others that you have developed within the Comprehensive Breast Center at IRMC?
Absolutely. There's variation from hospital to hospital and center to center. And we, as you know, were the first center in Western PA to get national certification for our breast program by the National Association of Programs for Breast Cancer Centers. And that is run by the American College of Surgeons Commission on Cancer. It's the same institution that certifies cancer centers across the country. And by doing that, we have to meet or beat national standards. And we have to put our data out there, and we have to make sure that we are doing better than the national standards. Mm-hmm. It's a very rigorous requirement to go through, and we're actually up for our 3-year recertification because we got an unconditional 3-year certification at our first evaluation. And that's pretty unusual to have an unconditional certification. So we're up this year for our 3-year reevaluation because you get a 3-year certification. But so, you really want to be seen by a center that has that national certification, because otherwise I can tell you that, people shoot from the hip and maybe their information isn't up to date. And by doing that, everybody involved in the whole breast cancer team, not just the physicians, the physical therapists, the dietitians, the technologists, all have to do graduate education on breast cancer every year and have to submit that to show that they're keeping up on it. So not only does your facility have to be state of the art and all that, but your doctors, your nurses, your techs, your dietitians, your physical therapists all also have to stay up to date on breast cancer.
Dr. Dan Clark, our guest this morning here on Indiana in the Morning. When you set a standard like that for the very first time, I'm assuming it's sort of like the Boston Celtics. They won all of those championships back in the 1960s because they kept getting better, and so that becomes the goal for you.
Right. And in talking about getting better, we haven't sat on our laurels here at all. We've talked before about all the increasing technology we've been getting. We have intraoperative mammography now, an imager that where when we do a lumpectomy, Dr. Bill Mori and I put the specimen immediately in this intraoperative imager right in the operating room, and we can image the specimen and make sure that we've got good margins around it, things like that. We've developed a MagSeed program where you don't have to have a wire in your breast to go to have a surgery done. We're increasing actually right now. We're having a brand new MRI installed. When I was first recruited here a little over 5 years ago, we didn't do breast MRIs in Indiana. And, and I said, if you want me to come, we have to strive to become a nationally certified breast center. And one of the first things you have to do is have 3D mammography everywhere. And we've talked about that on your program. Other people have about, the 3D mammography now is available in 3 sites here, Blairsville, and now in northern Cambria. But we had to have breast MRI. And I've said before, it was easy for me to do this here because everybody wanted to do it. It was like they just needed somebody to come in and say, this is what we need to do. And everybody's like, okay, let's do it. You know, the administration had the backing, you know, I have to mention the Healthcare Foundation here. You know, Indiana Healthcare Foundation, the amount of support they give to the breast center is just unbelievable. You know, with the Love of Life programs, you know, the Luther Ford golf tournament, you know, the amount of money they raise throughout the year has enabled us to do all this. And we're having a brand new breast MRI installed. It's not just for breasts, you know, it's a whole new MRI, I should say. It's going to be the best MRI in all of Western PA, and that's going to increase the clarity of the images and everything else for our breast MRI. We just put a breast MRI in 4 years ago, and now they're completely upgrading the entire MRI system. This year, our volume of breast ultrasounds has increased so much since my wife arrived, and we now have availability of a dedicated breast radiologist. You know, all she does is breast imaging. So our imaging volume has increased to the point where we're buying a brand new ultrasound machine and redoing a room in radiology for another ultrasound room, because to keep up with the demand we have for breast ultrasound, and it'll be used for other ultrasounds as well. So yeah, we've just continued to improve.
I think one of the interesting things about it to me is that even with all of the technology that has come in, it really still revolves around the people who are operating the machines, but more importantly, dealing with the patients, making sure that it's case by case. Everybody is an individual with individual concerns and individual problems, individual histories. And that really is the bottom line, isn't it? That's where you start.
Right. And, you know, our national certification isn't all about the doctors. You know, it's the team. And, you know, they care about what the doctors are doing, but, you know, the doctors have to be up to speed, but the entire team has to be up to speed. And along our journey to get the National Breast Cancer Certification, we became an American College of Radiology Center for Excellence in Breast Imaging. That's the highest recommendation they give, or certification they give, to a radiology department for breast imaging. And that's because all the techs went out and got trained. And, you know, like I said, it was so easy because they jumped on it. You know, and Darla, who runs, you know, radiology, the manager down there, does a great job. But all the techs were interested. They wanted to do it, you know, so they've all become certified in breast imaging, you know, and my wife was concerned when she left where she was and came up here. She was worried that she wouldn't be busy enough. And what would the team be like? Because she helped establish the whole breast program where we were. And, you know, she was concerned about that. And she absolutely loves it here. She says the commitment of the people here and the concern they have for the care of the patients and their level of dedication and their level of expertise here rivals anything. And so she's been very pleasantly surprised. And I said, I'm not surprised, you know, but she didn't know it. And she came up here and she can't believe, you know, in the women's imaging department, just the quality of the individuals that she works with.
We always run out of time. We never run out of questions for Dr. Dan Clark. And we could keep doing this for a long, long time, but we're just about done here this morning, and we need to move on. But one last time, women have to get that screening mammogram. That's where you start, and everybody should pay attention to that. Right,
absolutely. Age 40 with average risk. And like I just want to touch real quickly on the high-risk screening. If you do come back with the high-risk screening, you know, we do supplement that with breast MRI. And there's some institutions out there that are pushing whole breast ultrasound instead of breast MRI. When you look at the data in high-risk women, whole breast ultrasound will pick up an additional 3 to 5 cancers per 1,000 high-risk women. Breast MRI will pick up 15 per 1,000 high-risk women. So they do not replace each other. Ultrasound should really be reserved for women who can't get breast MRI. Mm-hmm. And if you have dense breasts or you're in the high-risk protocol, you will qualify for breast MRI for additional screening.
He is Dr. Dan Clark. Thank you so much for the visit. We got to do this more often. You know?
Absolutely.
It's the voice of Indiana County. It's WCCS 101.1 FM, AM 1160, WCCSradio.com. Jake is in the newsroom. He's coming up right now, the CBS Sports.
This is Boomer Esiason with the CBS Sports Minute. Bill Belichick earned my first game ball for career win number 300. An upset of Buffalo, and Kirk Cousins was a gutsy quarterback on Monday night against San Francisco.